Can you please pass on the message to the others if they're interested? Ask them to. I know they would have been interested in come right now. Yes, so let's start. Yes, I need your attention, please. At least now that I've said let's start, I need your attention for this session. And let me tell you, this session is going to be very useful for you for the exam also, and for the OSCE and for the OSCE and for your written exam. So I need all of your attention, and I'm sure you will benefit from these sessions. And that's why this has been designed to help you all. So first of all, I'm Dr. Sujata from the Department of Anatomy. I would like to welcome all of you, and I know you're all having a very, very bright future as doctors. So you are now in the process of making of a doctor who's going to make a difference in the lives of the patients, right? You all agree? Yes, inshallah, all of you will do well in your lives, and we would love to see you as a very successful doctors in future. So with that, now let me come to any idea what we are going to do today? No idea. Do you have any idea what's going to happen today? All departments. Did you receive the PowerPoints? I mean, in the blackboard, did the leader share with you the PowerPoints? You have the PowerPoints. Good. Did you all go through it? Okay, good. You didn't go through it? Good. Now you'll go through it. Yes? So now, let's see who are the people involved in getting this together for you. I really appreciate all the faculty who have been actively participant in this whole team, and for which, because of whom we are here today. So we have from physiology, we have Dr. Talayar and Dr. Professor Hariri, who are here already. And from anatomy, we have Dr. Sujata, myself, Dr. Kamal, Dr. Shajia, and Dr. Asim, and Dr. Shajia is here with us. And from biochemistry, Dr. Shakil, who will be joining us soon. And from microbiology, we have Dr. Nada, Dr. Ayman, Prof. Ayman, sorry. And from pharmacology, we have Dr. Fadil, Dr. Mayad, and from clinical skills, Dr. Nadia. So many doctors have worked under our team leader, Dr. Rashid, who is the chairperson of anatomy department. And with his direction and the guidance, we've all worked under this team to get this together as a musculoskeletal module for you. You would have noticed that in the last 3 months in the second semester, you've been taking in anatomy and physiology and other subjects, you're taking things related to musculoskeletal system and some infections, right? And also pharmacology, you've been taking about painkillers and things like that. So we are trying to get all the topics concerned to musculoskeletal system in the body together to form this module. So under the guidance of Dr. Rashid, me as a co-person in this whole team, we have come up and compiled these cases for you so that your comprehensive understanding of the system is better, so you can apply it better on your patients. Okay? So now, can anybody tell me what is all this? Here, as you can see, you have yes. Here, sorry, so here you can see what are your, let me get the cursor right first, okay. Yeah, so now you all as undergraduate students who just come into the university have very interestingly attended the classes and then had very interactive sessions among yourself and with the teacher, and you learned a lot of things and also studied a lot of things, right? You learned many new things in medical field. And then you took exams. By the time you took the exam, you're like this, totally lost. Yes? Yeah, exam day is like that, right? You're totally lost with too much information. You don't know how to comprehend. But finally, what are you all working towards? You're working towards graduating from here and becoming a successful doctor. To become a doctor, you need to, So when you've learned so many things, you need to integrate it to become a successful doctor. You need to understand why you're learning so much in anatomy, why you're studying so much in physiology, pharmacology, pathology, so many subjects, and you're all stressed because you're taking too many topics. I know, you say one exam, we have 10 subjects, but why are we doing this? Why are we putting you through this? So that you can integrate to become when you're seeing a patient, you will not see a patient as, okay, I know this in anatomy, I know this. You're going to comprehend all that you've learned in this module to apply it on your students. So we need to prepare you for this from the first year. That's why we are having this process of where we put in questions, and in the exam you must have seen we put in a lot of critical thinking questions. We could have put just easy questions, straightforward question and make you pass, but that's not our aim. Our aim is to make you all critical thinkers so that you think and you analyze the situation so that you could give your best solution to the patients. Agreed? Yes? So let's make it a very interactive session today so that you will comprehend all that you have learned in the last 3-4 months and you can take up this exam better. Yes? So now today what are we doing here? Today we are preparing you like soldiers to prepare to write the VIA exam, which is the hurdle exam in the end of the 3rd year. We are going to prepare you to take up international exams like the SMLE, and we are going to also prepare you for your clinical exposure in the clinical years ahead. Okay? So you're all like soldiers now, getting ready for the exam. Yes? What are the features of a soldier? Strong. Okay, then confidence. Then yes, I want answers. Here today, let me tell you, it's not going to be me talking, you listening. You are going to talk and we are going to talk. It's going to be discussion. Yes. Yes. Flexibility. Okay. Confident to face the challenge in front. Yes. So we are preparing you to prepare yourself for the exam. I know it's a very tough, it's more difficult than a war. Yes. You are mentally challenging yourself to take this exam. So yes, we are going to prepare you to take this exam and also prepare you for a clinical years ahead. Already you've been exposed to PBLs. You've been taking real case scenarios and you've been analyzing it, but you didn't, through the whole process, hope you understood that you have learned a lot through your PBLs also. Yes? Agreed? Yes? Okay. So now let's go further to what we are doing today. We are going to have simple case scenarios. I don't know if okay, you can see the simple case scenarios, and all the simple case scenarios will have components from all the various departments so that we get the whole complete case, so you understand the whole from the presenting symptoms to management. Yes? So with this understanding we go further. So we are going to have to, as a team, work together to reach the destination. And what is the destination? To become successful doctors. There you can see I put both cute boy and girl so that you feel, yes, the girl should not feel left out, the female should not feel left out. Yes. So we have even the females there. Yes. So all of you are going to become successful. If I put only male picture, then the girls will think, no, they're left out. No. Now both male and females are going to be there on the top, try and doing your best with your knowledge towards your patient. Yes? Happy with that, girls? Yeah. Yes. So now let's go to the musculoskeletal module. So now the next 2 or 2.5 hours we are going to have discussions. We want you to be sitting with an open mind, but with the access to your internet so that you can discuss, see and answer. Now, before I go further, I want to tell, today we are going to divide you into 2 groups. Males 1 group, females 1 group, and the questions will be asked. After the question is asked, I want you all to discuss, and then whoever has the correct answer, whoever knows the answer will stand up and say yes. Yeah, then Dr. Shajia here will mark whether the males have answered or the female students have answered. So in the end, we are going to compile who is the winner. Is that okay for you all? Ready for the challenge? Girls, boys, I need interest here. Come on, you cannot be like this. Okay. All of you ready for the challenge? Yes? Okay. So let's see, it's going to be easy. But let's see who will fare better, the boys or the girls. Just to keep this, it's just a competitive spirit to keep the enthusiasm and the interest going. Yes? So now, with the musculoskeletal module, what are the common conditions that you would come across in a musculoskeletal? Okay, 1 minute. Can you hear me there? Yes. So what are the most common conditions with the musculoskeletal system that you will be seeing in your cases? I want you to raise your hands and one person will tell. Yes. Females. No. Yes. Arthritis. Is it injuries due to, I'm asking you, is it injuries due to overuse, exercise? Maybe. Okay, then next. What is this? What is the, where is the indicator there? Red mark. Calf muscle, so it's a cramp, muscle cramps. Could be. Yes, what is this? You have to stand up, raise your hand and stand up, then only you will get the points. Otherwise, we are not going to consider it. What is this? At least saying so, you people will, instead of sleeping, you will get up, stand and then sit, you will feel yes. What is that? Yes. Come on. What knee what? Injury to the knee. Girls, boys, you have to raise your hand and stand up. Anterior cruciate ligament, very specific. Very specific. Knee joint, okay, injury to the knee joint. Then what is that? Raise your hands and stand. Yes, stand. Then only you get the point. Yes. Neurological, yes, she gets the point. Yes.
That is 1 point.
Raise your hands and stand. Raise your hands and stand, then you get your point. Yes, you know you stand up. Whoever stands up, you raise your hands, so you have to stand, then you get the point. Yes. Sorry? Graves. What is that? Stand up and then. Osteoporosis. Okay. So now, most of you are right. Yes. So let's see what are the important causes. And what are the important clinical cases you would see in the musculoskeletal module. One would be injury to the bones, joints, and the muscles. Usually it's an accident or a sports injury affecting the joints and muscles. Then it would be inflammation of the joint like in osteoarthritis. It could be an infection in the bone. It could be a muscle injury due to overuse or disuse also. Then you can have muscle cramps. You could have spasms. You could have injuries, nerve injuries, and you could have neuropathies like in the diabetes. And also you could have neuromuscular disorders like myasthenia gravis. Now I want you all to tell me what's the difference between a spasm and cramp. Look up. You have the liberty to look up at your whatever resources you have, but tell me the difference between a spasm and a cramp. So whoever stands up and answers will get the mark. Yes. You have only 30 seconds. 30 seconds.
If it is for a short time, it could be spasm. If it's more than like 10 seconds.
Short time it is cramp.
Yeah, that's not done.
Yeah, long time it's then you need, yes, that is spasm. Yes. Yes? Okay. Now coming to the I want you all to answer this for me so that you can discussion, yes, but when we don't want to totally abstract it, yes. Now, what I'm trying to tell you is, yes, answering is right, but you learn from this. Yes, this is a learning process. So now coming to the first case, I want one of you to read the lines. Who will read for me? Yes, please stand. Yes, read loudly, yes.
A 35-year-old Greg Conley was involved in a motor vehicle accident which sustained a traumatic injury to the chest and a sharp rod of pierced through the left arm.
Yes.
Upon arrival at the emergency department, the patient is hypoxic and complained of shortness of breath, difficulty and painful breathing. He also complained of pain in his left chest region. On physical examination, the doctor noticed paradoxical movement of the abdomen during respiration. The patient also exhibits pain and signs of respiratory distress.
Thank you very much. Now, I want among yourself to discuss and tell what would be the probable reason for the pain in his chest region.
why? Because radiating pain to the left arm.
It gives radiating pain. There is pain in the left arm. It's not radiating. We also complain. Yes. Okay. Yes, no, okay. Yes. Yes, trauma to the chest, maybe broken ribs. Yes, then what else will you think? Why is he having to? Okay, if there is broken ribs, what will happen? Sorry? Yes, maybe that's why difficult in breathing. Very right. Yes. So now patient is exhibiting pain and signs of respiratory distress. So let's see further. Yes. Now what is this? What is this? What could be that? Hand. Mashallah, very good. Very nice. Sorry? So he's having some pain in the hand. So what does that mean? See girl, this is where you need to learn. You're having a serious pain in the hand. So next thing, what should run in your mind? It should be nerve or it could be muscle. But here he didn't have an injury. So it could be involvement of nerve. The next question in your mind, what nerve is seen in the hand? So now, Rahman is also complaining of severe pain and numbness in the left hand. Pain itself would indicate injury to pain, only pain, related muscle and bone. If it is numbness, then what will it relate to? Yes. So what is the probable reason for this? Injury to either ulnar nerve or median nerve, because this is what you are going to see in the hand, right? Agreed? Yes. So now on examination, the doctor also saw that he sustained a deep cut, 3 centimeter long medial aspect of the left arm. So now, which nerves are probably involved? Why?
Medial aspect.
Girls, you have to raise your hands and stand up. Come on. Yes. Ulnar nerve, why? Yes.
Since it's in the medial part, so if the injury is in the medial epicondyle.
Just above the elbow on the medial side, you will see the injury. Where is it? So in that region, what will the nerve be there? Ulnar nerve. The most probably nerve that would be damaged because of this piercing injury would be ulnar nerve. So now if he has got an ulnar nerve damage, what is the most probable symptoms he will have? Anybody? Raise your hand and stand up. Yes. Yes.
No hand.
Claw hand. What do you mean by claw hand? Yes.
Because he includes the medial half flexor distal broken that, and he includes flexor carpi and narrow. So the function of them will be lost and his hand will be lost.
So why is it like this?
Because the weakness in
Weakness in 1 minute. Yes. Weakness in yes. Stand up. Girl, yes. Intrashay also, but what about the lumbricals? And what about the thenar and hypothenar muscles? Raise your hands and stand up. There is hypothenar muscles. So now here, see, he had sensory impairment to light touch or pinprick in the little finger and half of little finger. So he lost sensation also. Not lost, he's having disturbed sensation. Then there is weakness of abductor digita minimi and a marked weakness of occiput digita minimi, introshay and adductor pollicis. Agreed with this? Yes, so this is clearly ulnar nerve involvement. Yes. So now what is the management of the wound? What would be the management of the wound? Yes.
Cleaning and dressing.
Yes. So you clean and dress the wound. So how do you do the cleaning and dressing? You have learned it in the first aid, or you learned it in the clinical skills, right? No.
No.
Okay. So now what are the? Okay, you did the dressing. Why are you doing the dressing?
To ensure no infection.
Is it to no infection or to heal the wound better?
Infection.
So prevent exposure to infections and wound healing. If there's a gaping wound, you need to bring the skin together so it heals faster. Yes? So now a dressing is done on the wound and now the doctor is thinking of investigation. Now what investigations? Please don't look at the slide. I know you're looking at the slide. Okay, let's do this. Okay. I know you're seeing the slide. Yes, okay. Now I know. So what is this? X-ray of the chest. Then what is this? Conduction. Yes. And what is this? Electromyography. Sorry, electromyography. So now the doctor advised for a chest X-ray, EAU, X-ray of the left arm. He's also suggested nerve conduction studies and electromyography versus nerve conduction of the upper limb. Okay. Now, based on all the clinical findings, we'll discuss the clinical findings. Okay, so he had fracture of 4th, 5th, 6th left ribs, because of which he was having respiratory distress, and his nerve conduction release and other nerve injury like we discussed. So now I give it to Dr. Talaya to come. Dr. Talaya will come and discuss with you physiology aspect.
So you have done nerve conduction studies? There was a lab. So what do you expect to see here in this particular case? If you do nerve conduction study? Low conduction? What do you mean by low and low? Okay. So basically the primary thing, yes, I want to say. Slowed velocity. Why do you say that? No, whatever you say, you have to defend that also.
This was the last page in the
But now you can think, it's not essential that you have to recall certain things. You have said conduction would be slow. What could be the cause of that slowed conduction?
Stand up and answer, please.
So we lost fibers, we lost branches.
Yes, please. Axon loss. Demyelination. So you are bringing all the possible things, but what would be here? All right, we have to decide between two things. One is whether there will be a conduction or low conduction. Yeah, we need to do that first. Okay. Yes, please.
It depends on the injury. If the injury was severe, it will be very slow conduction. If it was mild, they would be conducted, it would be very slow.
Okay, there is a very basic point here. Conduction defect would occur when there is demyelination. Okay, because you all know that myelin increases speed of conduction. Is it clear, straightforward thing? In this acute case, there is no demyelination. Okay. Here there is loss of actual nerve fibers. They are cut. So the message will not go forward, isn't it? So it does not mean a slowed conduction. It means the overall amplitude of the signal would be very small. If there are some fibers left, if there are no fibers left, all of them are cut, then you won't have any signal. If you stimulate the nerve, if you stimulate the nerve, say for example, after it has been damaged, from that side you would have a full-fledged signal immediately because the fibers are still there. They need time to degenerate. But if you take the stimulus from above the site of injury, then what would happen? No signal would be going forward. If there are few fibers left, very small signal would be there. It will not be a conduction defect, it's an amplitude defect. Okay? It will be an amplitude defect, and that would be if you do it from the proximal side. So, this is what is given there. Somebody could read just to, who is going to read? Maybe there are a couple of points that would help you to remember the things there. Yes? Yes, please. You want the mic?
Want the mic to read? Read.
No need. Yes?
Okay, no need of mic, they can speak loudly. Yes, girls. Yes, read.
And identify the main points. So what does this mean? The last one? Did you get the last point? All right. So just to re-emphasize, just keep this thing in mind. If the axon is gone, you have got a reduced amplitude. If there is demyelination, then there will be slowing in the conduction. Okay. Now in the nerve there are all types of fibers, small fibers, large diameter fibers. That's why there might be some evidence that slowing has occurred if a few fibers have been left. Okay. And what do you expect in electromyography? What's the difference between nerve conduction and electromyography? Yes. So what do you expect in electromyography? Yes. Here you are checking what? In electromyography, you are checking what? It is muscle contraction or electrical phenomena in the muscle. Yes, it's causing the muscle. So what do you expect in this case, in electromyography? Yes, depending upon how many motor units have been lost, isn't it? How many nerve fibers have been cut, so there will be lack of response from motor units. Again, the amplitude would go down. And another thing could be, after some time, do you remember what happens in lower motor neuron lesion? What happens? Yes. What else? What else? If there is loss of innervation of a muscle, what would happen? On long-term basis, it will be wasting. But if you do electromyography, there will be fasciculation and fibrillation. You remember what is fasciculation? What is fasciculation? There will be spontaneous contractions of the small parts of the muscle. So this is because of the spontaneous nerve impulse generation in the some of the remaining nerve fibers. Okay, so that would be there. So EMG may show abnormal spontaneous activity and reduce amplitude of the electrical signal. So these are the things which you are going to expect in nerve conduction study and electromyography. All right, my thing is finished.
We'll come back to the one. So, you know what's the problem, right? What's the main problem? You have injury, right? And this injury associated with two things related to the pharmacology, right? We're gonna have what? And pain and what else? Infection, right? And this is one, right? So what type of the infection do you expect? Of course bacteria, but what kind of the bacteria? Right? Maybe gram positive, maybe gram positive, negative, anaerobic, right? Okay? So, what would be the further management for the cut one, fracture ribs and the veins in the hand? So, I think we not covered this one, using tetanus shock. Do you, anyone has any information about tetanus shock? So we are worried on the mycobacteria, right? Okay. So what? So this bacteria secrete toxic material, right? Toxic material. And this toxic material, what happened? It will, first it will be absorbed through the terminals, then will be traveled back to the spinal cord and deplete inhibitory GABA and lysine. And what we end up, we're gonna have excitatory, right? So this is the purpose for the tetanus. So the tetanus vaccine, which is enhanced our body to produce antibody, and this antibody will scavenge this toxic material. Physician prescribed a combination of the varicella, tazobactam, and metronidazole. I think the answer is here, right? Also, why we use this, what we call it this one? What we call this one? I mean, this is a combination of the antibiotic without define the exact microorganism. What we call it? Empiric therapy, right? So, and this, this combination, piperacillin and tazobactams and metronidazole. So, piperacillin and tazobactam will cover gram positive and negative. What about metronidazole? Anaerobic. Good. So also ibuprofen was prescribed. Why? What else? So now this is the answer, but we need more details. Okay. So why was the combination of piperacillin and tazobactam chosen for this patient? Why we use the combination? Because we have wound, right? That mean, if we have wound, that means more susceptible to a variety to the polymicrobial infection, right? Including MRSA, right? So this is the answer: to provide a broad spectrum coverage against gram-positive, negative, and anaerobic bacteria commonly introduced in the traumatic wards. Second question, briefly describe the mechanism of action of the piperacillin and tazobactam. We have two drugs, right? Piperacillin and tazobactam. What is the mechanism of the piperacillin? How? How piperacillin inhibits CYP? What? What's the enzyme? What is the site of action for the piperacillin? Piperacillin. What is the enzyme? What is the enzymes involved for the cross-linking? Transpeptidase, right? So this inhibits transpeptidase, right? Right? What about tazobactam? Beta-lactamase. What is this beta-lactamase? Who secretes this enzyme? Bacteria. And what's the action for this enzyme? Will no. So it open what? Beta. So after we open this beta-lactamase, what happened for this antibiotic? Inactivated, right? So the piperacillin inhibit the enzyme transpeptidase, which is essential for cross-linking between peptidase glycan, right? But if the bacteria secrete what? Beta-lactamase, we're gonna inhibit this enzyme by tazobactam. So the second question, what is the mechanism of action of the ibuprofen? What is ibuprofen? How many enzyme cyclooxygenase we have? 2. COX-1? So which is responsible for the inflammation? 2. What about COX-1? Where the mainly express COX-1? In the GI? Right? So ibuprofen, is it selective or non-selective? Non-selective, right? So inhibit cyclooxygenase 1 and 2 enzyme, reducing prostaglandin, right? Once we decrease the formation of the prostaglandin, we're gonna prevent inflammation and pain. Last one, what's the major gastrointestinal side effect and why? But how this happen? Prostacyclin, right? So what's the physiological role of the prostacyclin in the GI, in the stomach? Prevent peptic ulcer, right? How? Decrease what? Acid secretion. What else? Increase mucus formation. And what else? Increase blood supply, right? And this will enhance turnover. I think. Okay. Also, how we can avoid this peptic ulcer? By what? Yeah, I'm taking after me. Okay. You got it?
Okay, so now we continue with the case. So we still have a part of the case which is still not discussed. That is, why did he have respiratory distress? We know it is the fracture to the ribs. But which is the muscle responsible for the which is the main muscle of respiration? Diaphragm. So now I want answer for this question. I'll give you 2 minutes. Refer to your. I want all the boys who are sitting quiet and the girls refer. You can refer your lecture, your whatever. So what is the function, nerve supply, and damage? Yes.
So right now, the pressure enters the body.
Okay.
So the nerve supply is very
Very good.
from C3 to C5.
Mashallah, very good.
And the resulting damage, if it was damaged, the pressure will be impaired. And the healing will be difficult. Also, he had a fractured rib.
Yes.
We play on chest.
Yes.
Okay. So now,
Very good. The diaphragm is a muscular partition, separates the chest from the abdominal cavity, and she very nicely explained the action. So what is that action called, where it comes down and increase the length and yes.
It contracts for inspiration and relaxes for expiration.
Okay, but what is the movement called? Yes. What is the movement called? Bucket handle is the ribs. Diaphragm. Diaphragm. Where it comes up like this. Bucket handle is for the ribs. Yes. What about the diaphragm? Piston action where it comes down and increases. Yes. Pump. It's a pump action. Yes. So that's and the nerve supply is phrenic nerve. So injury to phrenic nerve or paralysis of the phrenic nerve will lead to a paralysis of the diaphragm. Can it be visualized in the X-rays? I'm just asking random. This is not the part. Diaphragm paralysis. If the diaphragm is paralyzed, what will happen to the diaphragm? Will it still be a dome or flat? Flat. So in the X-ray, will you see it or not? In the chest X-ray. The chest X-ray, the diaphragm is dome. Yes. So if the diaphragm is paralyzed, it will be a straight line.
Why is it done?
Because the muscle is, how is the shape of the diaphragm muscle? Taking origin from the periphery, getting inserted to the central tendon. Yes? Yes? So it's getting inserted to the central tendon. So if the muscle on one side is paralyzed, the muscle will be flat. So in the chest X-ray, you will see it as a straight line. Yes? You will not see the dome. In the chest X-ray, I'll go back to this picture. Just sorry, I'm just quickly going through that just because I covered this now. I'll just show you that. Yes, here. Can you see the... Here, this is the chest X-ray. Here, this is the diaphragm, right? You can see the dome. Yes? If the diaphragm is paralyzed, it will be a straight line because the muscle will be down. Yes? Okay? Sorry. Yes. So now, what are the nerves that we see in the arm? But just name the nerves that we see in the arm. See, but one boy is answering, I don't want this, I want everybody to take part. The one person is answering, no, yes, yes, yes. Axillary nerve in the arm. You see it in the arm? See, this is where you need to think. We are asking not upper lip, we are asking arm. Okay, girls, now second chance, yes. Musculocutaneous nerve, mashallah, yes, boys. Sorry? Radial nerve. Okay, radial nerve, yes. Anybody else? What is? Sorry? Median nerve. Any other nerve? What nerve is the ulnar nerve? So in the arm we see these nerves, right? But, okay, now let's discuss what are the lesions associated with each of the nerve. Now if radial nerve is damaged, what is the lesion? Radial nerve is damaged, I'm asking, what is the lesion? What is the resulting lesion if the radial nerve is damaged? Wrist drop. Wrist drop. Okay. What is the anomaly if the median nerve is damaged? Raise your hand. Ape-like hand. Yes, ape-like hand. Okay. Ulnar nerve we already discussed. Claw hand. Yes. And what else nerve we have here? Musculocutaneous nerve. Okay, we come to this question. Answer to this? Yes. Now musculocutaneous nerve supplies what? You said musculocutaneous nerve. The musculocutaneous nerve supplies what? Yes. And brachioradialis. Yes, bicep. Brachialis, brachioradialis. Yes. So now if lesion to the musculocutaneous, now what will happen? Pronation, supination is a bicep. What's the action of biceps? Patient will be able to do it now. Yes. So now you know how you are supposed to be thinking for each of them. So now, okay, we got more details. I have put the lecture from you can take all the details. Now coming to this picture. Now the question is, identify the muscles and name the structures in the intercostal space. See, one person, no. No. He's already raised his hand. Let everybody think. Yes, I know you have done, yes. Okay.
Fascia.
Okay, yes, you please stand up. I'll give you a chance. Yes. You're discussing, after raising your hand, you're discussing. Yes. Okay, yes.
The muscle, external intercostal muscle,
Yes.
internal intercostal muscle,
Yes.
and the most intercostal muscles.
Okay.
Under structures, vessels of the intercostal muscles are met.
Okay, where do you see the intercostal vessels and nerves? Yes.
Between the limb and the structure.
Mashallah, very good. So full marks for the boys, but really happy to know that okay, you know this. So now you know patient diaphragm is one involvement in the respiratory distress. Other muscle that is responsible for the breathing is the intercostal muscles. Now, what is the action like we already discussed? The bucket handle movement is the one that causes the ribs to go up and down and cause the movement of the respiration. Yes. Now coming to clinical skills, today the third year are having OSPE exam, so we do not have the clinical skills people here, but just revising history taking for this patient. I'll just go through it. What you do in the history taking for this patient? What questions will you ask? Raise your hands and answer, right? What are the questions you will ask? Clinical skills. What are the questions you will ask for history taking in a patient? Yes. Sorry? Morning. Okay, but here he is having an injury. Yes, what is the question? Yes. Okay, previous injuries, yes. How will the patient know? Yes, first important question, describing the pain. Pain, the type of pain. Yes, and describe the pain. Exact. You know, QQA, you've done that in the PBL. Who said? But I asked you to say, raise your hand and tell us. Okay, what are the things? Okay, tell me, what are the things you asked? QQ? Eliminating factors, driving factors. Yes, then. Okay, then. Any questions? Okay. Will you ask the past medical history? Will you ask about diabetes? Will you ask about any other illness? Hypertension. Then?
Medication.
Any medication? Any allergies? Smoking. Yes, very good. So now, okay. History taking. Now coming to neurological musculoskeletal examination of upper limb. You finished your OSCE exam. So you are all perfect with that. Yes? So we go, can you all discuss among yourself this, or you want us to go ahead? No, enough. You had enough exam. Yes. Answer this question. Yes. Yes. It's there in the slide. It's in the slide. It's in the slide. You can see the answer. Fortnite sign, have you taken girls? They're saying no. Girls are saying no. Boys are saying no. Okay. You did it? One boy says yes. Rest all says no. Okay, what is Fortnite test? Can anybody tell what is Fortnite test? Sorry? Yes, what? See, that is Fortnite test. What you telling is not Fortnite test. This is Fortnite test. Ask them to hold the paper between the fingers. Between the thumb and the index. Yes? Yeah, what he's telling is true. Yes. this, asking the patient to hold the paper like this. And so if there is a lesion, what will happen? Have you taken this? Yes, no? Yes, so that means it's been done. So only one boy was right that it has been done. Rest all of you said no. Yes? Okay. So you know this, right? So next let's go. This is the second case. Now we are done with case 1. So in case 1, anybody can you just give me a brief run through to the case 1? Who will do a brief run through case 1? So what did we have? Rahman having an accident, following which he has injuries to his chest and left upper arm. So a piercing injury, so it's open injury, so it needs suturing, dressing. So what are the complications, probable complications? Infections, wound not healing. So you give them, so you think about giving him a combined antibiotic like Dr. Kadil discussed, and you will, obviously he has severe pain, so you will give him NSAIDs, and of course he has fractured ribs, because of which he has respiratory distress. So you manage the fracture. I know as second year undergraduate it's too much to discuss management of fractures, so we'll not go into it. But then you have to, as basics, we have to revise history taking, clinical examination and injuries, and compare between ulnar nerve injury, median nerve, radial nerve to identify what injury is having. Yes? Clear? So now let's go further to the next case. Here we have a lady, Amina. So anybody who can get up and read the case for me? What is this now picture? What is this picture talking about? Sorry? Diabetic neuropathy, yes. So now can anybody read this for me? Can you read it? Anybody? Girls? Anybody? Boys? Anybody can read this? Yes, please. Yeah, read, yes. Yes, read. Read.
With a 10-year history of type 2 diabetes, present with complaints of bilateral lower extremity numbness and tingling that have been progressively worsening over the past year. She described the sensation as a pins and needles feeling that is worse at night and affects her ability to walk.
Yes. So what is happening here? What has happened here? Anybody? What do you think is the reason? Diabetes peripheral neuropathy. Okay, we agree on that. So now, before we go further, we need to know what are the nerves taking the sensation from the foot. So what is the nerve supply of the foot? Raise your hand and stand up, I'll accept your answer. Who will take it? Yes, I have only 2-3 boys and 7-3 girls. Yes, please.
About the sensation we have the global pain.
Yes.
There are many nerves.
Yes, many nerves. Many nerves, yes.
Like Indian nerve.
Like, no, tibial nerve in the leg. What about the foot? The question is here, summarize the nerve supply of the foot. Yes. Yes. So you have a medial plantar, plantar nerve, and okay, you have a tibial nerve, which is dividing into medial and lateral. They supply the muscles and the skin here. Other than that, what about the other nerve? Other nerves, sorry. Okay, other nerves. Okay, so you have these other nerves which are supplying the skin of the feet, of the plantar aspect of the foot. So you have medial plantar, lateral plantar, saphenous, medial calcaneus. Okay, now, so where the patient is feeling the tingling and numbness along these nerves and also along the nerves. Okay, now what are the sensory nerves to the dorsum of the foot? Superficial and deep peroneal. So now you can see the whole nerve supply of the foot, dorsum and the plantar aspect, all the nerves, superficial and deep peroneal and plantar aspect like we all discussed. So now, where are all these nerves coming from? Where are all the nerves to lower limb coming from? Where are they coming from? Only lumbar plexus? So you have lumbar plexus and sacral plexus. Lumbar plexus, what are the root values of the nerves coming out? L4. Okay, now next. What are the nerves from the lumbar plexus? No, not L4. Yes. That is safe. I am asking what are the branches from the lumbar plexus? What are the branches from the lumbar plexus? Okay. Okay, four nerves. Mashallah, what you're saying is right. The four nerves from the lumbar plexus in the lower limb. Femoral, lateral cutaneous, obturator, and you have the lateral cutaneous nerve here. Yes, these are the four nerves. What are the nerves from the sacral plexus coming out? Inferior gluteal, sciatic, and you have the posterior femoral cutaneous nerve. Yes. Now, like you said, okay, sacral plexus coming from L5 to S1. Yes. Okay. Now that's about the nerves. So now, who will read for me this part of the story? I want one of the boys to read it. Yes. Or any girls from there? Yes, please read loudly. Yes.
On examination, the patient had joint skin with decreased sensation to thigh, to light touch, bend and temperature in a sucking blood distribution in her feet and lower leg. She also exhibits decreasing anterior reflexes and impaired vibration and proprioception. On further examination, she also had cracked skin on the face, possibly due to the decreased sweating. Blood pressure recording indicated orthostatic hypertension, drop in blood pressure above standing, indicative of autonomic nerve fault.
So now, before we go further, we need to know the dermatomes of the lower limb. Can you all see what are the dermatomes of the lower limb once before we go further to the physiology part? You know the nerve supplying the lower limb. Now, what are the dermatomes? Because the patient is complaining of pain in certain region of the skin, so you need to know the dermatomes. Can you all look up? You just have to open up your nerve supply to lower limb PowerPoint and you have it there. You open the PowerPoint, you have the picture. L1, see obviously it is from the plexus from where it has come. L1 to S3, S4, yes? See, this is the dermatomes of the lower limb. When I say dermatomes of the lower limb, this region by L1, this is L2, L3, L4, 5, S1, S2, S3 and S4. So from L1 to S4 we have the nerve supplying the skin. You have to be aware of this when you're going to the patients. Yes, you need to know the dermatomes. And that is the area now the patient is complaining of tingling, loss of altered sensation in the leg. When I say leg, it's from the knee, from the ankle and in the foot. So these are the dermatomes L4, L5, S1 and S2 involved. And what are the nerves involved? The common peroneal nerve and the saphenous nerve here. Yes? So these are the nerves which are taking these sensations from the lower limb. Now coming to the physiology component, I give it to Dr. Hariri, who will come and explain to you the next.
السلام عليكم. طيب الحمد لله رب العالمين وصلى الله وسلم وبارك على نبينا محمد وعلى اله وصحبه اجمعين. Welcome everyone to this session. Really, a lot of efforts has been made to organize these sessions. Imagine a lot of WhatsApp messages. Doctora, she is working up to this moment, I think, without sleeping, isn't it? I'm right. So getting back to this, and the main problem is diabetes. Here, the question is explain the autonomic involvement in the diabetes. Do you know first what is the other public name of diabetes? What they call it? No, the public name. The exact. What?
مرض disease.
أيوة من اللي قال؟ ارفع صوتك ابني. ارفع. ما سمعتك.
Mother disease.
Yeah. 1 point. 2 points here. Mother of the disease. Why? أيوة. Just a minute. Yes? Yeah, it's open the gate for other disease. Other point here. So open the gates for disease. Believe me, believe me, any persons with diabetes, every cell, not organ, every cell is going to affect. The matter is the time, only the time. And diabetes considered it is the most common non-communicable disease worldwide. And Saudi Arabia among the top 10 countries. Take care about yourself. So diabetes start after, it takes near 14 years. And لما أقول لك عندك diabetes means it takes time to develop. And please take care. Your lifestyle nowadays, unfortunately, we are following حاجات ما أنزل الله بها من سلطان. So, طيب, again, why mother of disease and open the gate of other disease? What is the concept behind? ليه? Why this story, bad story happens in diabetes? ليه? What was the first term you covered in physiology? في أول محاضرة إيش درسوه؟ What was the first term studied in physiology? Huh? Homeostasis. So the problem is that disturbs the cell unable to survive with hyperglycemia. This is now the starting point. So these patients, she or he, she. Huh? However, so this hyperglycemia leads to what? In our, we return back to this case. Hyperglycemia leads to through what? Why she had neuropathy? Why? What is the mechanisms? Hyperglycemia disturbs the homeostasis في الجلوكوز leads to what? واحد عايش في atmosphere hyperglycemia. This leads to what? In case of diabetes, what is the pathophysiological mechanisms involved in this? تفضل. ممتاز. One is oxidative stress. What does mean oxidative? دائما نسمع oxidative, antioxidant. What do you mean by oxidation? تفضل. بس يا شباب نسمع. أي مرة ثانية لو سمحت. Leads to what? What is the end? Disturbance for what? Yeah. يعني أكسجين يطلع واحد و disturbs again homeostasis disturb the cell wall. Can you imagine cell without cell membrane? This is the point. So like the bacteria, we are working against the cell membrane. The same things. All these oxidation, free radicals disturb or disrupt the cell membranes, leakage the organelles. خلاص lose the functions. One other mechanism. ها؟ DNA damage من ضمن ال consequences. Okay, what else? The main mechanisms. What's happened في diabetes? ها؟ ايش يصير؟ اي نحن نتكلم الان على النيوروباثي. في حاجه قريبه منها تفضل. demyelination كيف يعني؟ يعني يصير degenerative disease lungs because of what؟ قبل ما نوصل it is late stage degeneration يصير. طيب the main problem يا شباب في الديابيتس ايش يصير؟ ايش المشكله في الديابيتس؟ ايوه الهايبرغلايسيميا lead to metabolic disturbance and neurovascular insufficiency poor blood supply. طب ما بنطول حاجه ثانيه كمان بتلاقوها في الارتكلز they are speaking about the productions of the productions of glycated end products. Did you hear? حد سمع من قبل? What do you mean by glycated end products? It means your proteins and fats become fully with sugar, like HbA1c. However, all these things disturb the functions of the autonomic nerves. And as you know, how many branches of autonomic nervous system we have? So, how we can define autonomic nervous system? If someone asks you, what is autonomic nervous system? واحد بس. It is for involuntary organs. Okay, what else? لكن before قبل they represent what among the nervous system in general? It's represent what? Central? Peripheral. It is peripheral nervous system one. Sensory or motor? Afferent or efferent? It is the efferent peripheral, which supply this is the autonomic, and two branches, sympathetic and parasympathetic. So now all these, in brief, all these things disturb an autonomic nervous systems. And these lead to sequence of problems, like what are the examples we give you for the diabetic neuropathy? Now, خلاص, we know that this autonomic nervous system disturbed because of these pathophysiological mechanisms. Now, if the autonomic nerves disturb, what will be the sequences? Or the Give me an examples of neuropathy, diabetic neuropathy. The patient make compliance of diabetic foot, it sequences, blood supply compromise, infections, wound, complex. Starting with poor sensations. لكن في حاجات فرانك مثل ايش؟ ايوه؟ طيب في الكارديوفاسكولار كيف يصير reflections, the impairments in the function? What the patients can complain from? What is the most ايوه؟ ايوه مرة ثانية؟ What is orthostatic hypotension? Yeah. سمعتوا عن orthostatic hypotension؟ Now في حد عنده قريشة ما قررت ما طيب ما شاء الله تبارك الله. طيب imagine this is brain, the blue is brain and this blood. Okay, this in horizontal position, the blood reaches to the brain. If sudden stand up, what's happened? Poor supply. But the story in your blood, on your body, يعني how we can overcome this problem? ايش اللي حيصير؟ ايش حيصير؟ إذا عملت أنا فازو كونستراكشنست ايش حيصير معي؟ صح؟ حيطلع حيصير بريشر. أنا بعمل فازو كونستراكشن to supply the blood to the brain. عملها بس حيطلع الميجرو. ها؟ and these leads to increased blood pressures. شوية. لكن الناس هؤلاء ما عندهم شيء. طيب ما بنطول عليكم سوري. What other problems؟ تفضل يا مين. What other problems؟ ها؟ طيب في gastrointestinal. طبعا هذه problems the doctors doesn't know because all the doctors deal with the blood glucose. These symptoms no one has to take care about. In the gastrointestinal, what is the most common symptoms? ايش يشتكي المريض من ايش؟ Because of the diabetes, because of the neuropathy. Like what? Constipation, diarrhea, esophagus problem, motility, fecal incontinence, urinary incontinence, sexual problem. I mean, a lot. يعني imagine neuropathy and autonomic nervous system supply everywhere. So it can affect anything. طيب, which other sensory modalities should be treated during peripheral neurological examination for diabetic neuropathy and how? What else? What we should ask for? Vibration test. For what? Again, for distal joint. Right, what else? Now, look. We are targeting now peripheral neurological, and we are looking for sensory. أيوة. Rumble. Okay. What else? أيوة. طيب. Good. Any more? So, light and pain. Someone said Robert says, for what? Proprioceptions. How? Can someone explain? And he will go to 1 degree complete. How we can perform Robert test. تفضل. صوت عالي لك. لا بالانجليزي. لا تكلم بالانجليزي. So what are the instructions first? The instructions. Yeah, how to conduct. Yeah. Okay. What about the arms? Okay. شكرا. And of course, it indicates, as you said, problem on the proprioceptive loss, posterior columnar sensory neuropathy. How is Cronus tested and what does it indicate? Which type of movement? What do we call it? طيب, complete sudden movement? Limit for whom? Okay, طيب, indicate. Thank you. Okay, who can complete? اتفضل. Cronus. Upper or lower? Upper. So it is dorsal flexion of ankle while the knees or the knee is slightly flexed. And it is rhythmic involuntary contractions. Indicate the involvement of the corticospinal tract damage, upper motor neurons. So who will read now? صوت عالي لكن. Who can help us? من بيقرأ؟ إيش عارف؟ إيش العزوفة؟ تفضل. What is the normal? Normal. What is the normal HbA1c? Yeah, less than 6. 4 to 6. Less than 6, 5 to 6. Yeah, the variation 4 to 6. Yeah. So, what is the important now? To ask for nerve conductions in the active patients. ليش؟ Why? You are looking for? No. So we have already discussed about that collective. What would happen here? What do you expect this, please?
if there is demyelination, and if there is an axon damage, then amplitude. So both things are possible. In diabetes, there could be demyelination. Of course, then it will be a conduction defect, but there could be axonal loss also. And as it was written at the top, it is a length-dependent polyneuropathy. Anybody can just figure out what does it mean, length-dependent? Just at the top it is written, it is a length-dependent polyneuropathy. Anybody else? Any suggestion? What is length dependent? The more distant? Yes? Okay. Yeah, you are thinking in the right direction. But here it is, anybody else can give the input? Length dependent? Yes, please. Okay. All right, here the length dependent basically refers to the fact that the longer the nerve, the more likely it is to be affected, and the effect would be from the most distal area. So what is the typical presentation? We say glove and stocking. What does it mean? You are familiar with the word? Glove stocking type of peripheral neuropathy? Where do you wear the gloves? Hands. And where do you wear the stockings? So the longer the nerve, the more likely it is to be affected. So the polyneuropathy starts from the most distal parts, and then it usually progresses towards the center. Okay? So this is what is length-dependent polyneuropathy. Glove and stocking is a typical presentation, maybe more than 50% of the cases. It is glove stocking type of polyneuropathy in diabetes. And the other type would not be a length-dependent one. It can be starting anywhere. Maybe the polyneuropathy appears first on the face or on the chest or like that. Okay? So small or longer nerve doesn't matter much. So you could be having early detection of diabetic polyneuropathy with the help of nerve conduction studies. And all of you are familiar that if there is a demyelination, there will be a conduction defect. And how do you calculate the conduction? So very simple formula. You need to know the length of the nerve over which you are going to actually make the study, and then you need to know the time difference between proximal and distal stimulation. Okay? So all of you are familiar with that. T2 minus T1 between the peaks of the muscle responses from these two positions. Okay? So you always, you do not always get a conduction defect. Just keep this thing in mind. In diabetic neuropathy, if it is an axonal loss, there may not be initially a conduction defect. It is just the amplitude defect. Okay? Thank you.
Now I want one of you to read this part. Can you read this part, any of you, please?
learning? Yes, please, Amina, yes. Yes. Okay. Can you please read it out to me loudly? Yes, read it. Yeah, read. Louder, louder. Here, 1 minute. So now what is this paragraph talking about her management? How she can better control her sugar, diabetes. Yes? So the next paragraph, after a few months, she came to the hospital with a wound in the plantar aspect of the left heel. Yes, anybody can read now. Yes. Boys, somebody from the last there. Can anybody read it for us? Who will read? You will continue, please continue. Yes. On examination of the feet. Louder, louder. What is diabetic ulcer? What is diabetic ulcer? What is diabetic ulcers? Girls, I want everybody to think and answer. What is diabetic ulcer? No answer. No answer? Yes. So now, what will be the further management of the diabetic foot or the diabetic ulcer? Yes, antibiotic then. Sorry? Heal the wound, yes. So, first most important, you need to see that she is already having a discharge. So how do we take the swab from the wound? Anybody? You have done it in clinical skills, yes. Sorry? From the pus. Is there a way of taking it or just randomly you do? There is a way of doing it. Circular. Yes, yes. Have you done it in clinical skills? But you had it in the PPL, I remember. Wound swab taking was an activity in the PPL. Yes? So you cannot now restrict, this is the problem, you restrict your mind to only here. You have taken it in the PPL. Do you remember you took the swab, taking of the swab in the PPL? No. Yes, I remember there was an activity. So the swab is taken and finally sent for to isolate the microorganism. For this, Prof. Ayman is coming, he's on the way, he'll be reaching. So just give me a few minutes, he'll come and then let's discuss all this. So let's go to the, yes, here we have a part, yes, pharmacology part, which doctor will discuss.
So, welcome again. As Dr. Muhammad, Professor Muhammad Al-Hariri, this diabetic, it will be covered more detail in the third years. I used to give this lecture. As Prof. Muhammad said, diabetes is really disaster disease. It is multi-disease. Okay, first we come, we have problems with elevations in the blood glucose caused by hyperglycemia, and we need to fix this hyperglycemia or increased blood glucose by using a variety of medications. As you know, we have type 1, type 2. Mainly we use for type 1 insulin preparation with the different type. And we have 8 groups of anti-diabetic drug used to treat type 2. Okay? All these medications will be covered in the third years. For this, for this case, I'm not gonna talk about the anti-diabetic drug use. So I think Prof. Muhammad, he mentioned that one. We have diabetic nephropathy, and this one usually comes after long term uncontrolled, and this is well characterized by elevation of the glycated hemoglobin. Okay, so our goals to control blood glucose, to avoid let me say the short-term complication and long-term complication, the end organ complication. For example, retinopathy, neuropathy, cardio, or diabetic cardiomyopathy, impotence, many, endless of disease. And keep in your mind, diabetic is not associated with disturbance in the carbohydrate metabolism, but also lipid peroxidation as well as protein metabolism. And we have problems in the microvascular endothelial function. So, for the pharmacology, we're gonna focus on to treat diabetic ulcer. Okay. So based on the culture and the sensitivity result, diabetic foot infection caused by methicillin-resistant Staph aureus, right? I think we discussed this one in more details when we talking about when we cover the antibiotic, right? So we have two problems with the methicillin-resistant Staph aureus. Can you mention? What's the problem? What? Yeah. Change what? The ring this one for the antibiotic. So we have a mutation in the transpeptidase, right? This mutation prevents many of the beta-lactam to bind and inhibit transpeptidase, right? The second one, this methicillin produce beta-lactamase, right? For this reason, we have to use other medication, right? Can you give me an example of the antibiotic can use to treat methicillin? Vancomycin. What's the mechanism of the vancomycin? Inhibit cell wall through or via elongation, right? So what we discussed 5 types of the cephalosporin, remember? Huh? Third generation, second, third, 5, right? Can you give me example for the 5? Ceftaroline, good. What other antibiotic can be used to treat MRSA? Act in the cell wall. You said about the vancomycin. We have another one. Fosomycin, correct. What is the mechanism for the fosomycin? Inhibit and more enzyme. Thank you. So what? Okay. خلاص حقت الفيلم هي خلاص. طيب the question, what's antibiotic treatment methicillin foot infection act through inhibit the cell wall? We have 2 examples. We have 3 examples, right? Vancomycin, fosomycin, and ceftaroline, right? What about can you give me 2 examples of antibiotic act through inhibit the protein synthesis? موجود صح؟ linezolide, huh? Yeah. But what is the mechanism of the linezolide? This is the action. Inhibit. How? It binds with the large subunit, right? During initiation complex or elongation process? Initiation. Correct. Initiation. Okay, we're done. Thank you.
So next we go to case 4 because Dr. Fadil, Doctor, they have it out. They have it.
Yeah.
Okay, now let's go to case 4. We have case 4 now. We discuss case 4, then come to case 3. So Dr. Robert Thaler.
Alright, we start with this case. Actually, this is a case which I faced during my house job internship. The person presented in our OPD, and I was the one to face this person first. So, somebody can please read.
As an officer, 64-year-old male visit in the evening with a complaint of surgery to keep his eyes open while driving his car. His identity tells the following despite his disclaimer to keep his eyes open. He was lucky to be in a place where there was hardly any traffic, and he applied the brakes to bring the car to a halt. His companion then escorts him to the hospital where he was examined and investigated. History revealed that he had been experiencing some strange symptoms over the last 8 months, including severe eye strain, which for longer than 10 minutes. He noticed that he was feeling relatively more fatigued, tired, while chewing food or brushing his teeth for the last few months, and felt increasing difficulty carrying out other daily activities, especially towards the evening. The physician suspected myasthenia gravis.
Alright, so what are the indicators why the physician suspected that it is myasthenia gravis? Yes, please.
After the day, he can't do daily function, but in the evening, the function decreases and he starts not to.
Okay, so this is one. So what could be the reason for this? No. I am asking the reason why he is unable to carry out the thing. What is the basic physiological phenomenon? So why he is able to do the work initially? What? Why it happens after some time? But initially there is. Yes, please. Mm-hmm. Yes. Yes. Anybody? Yes, you are correct. Actually, yes. The antibodies are there, which are going to say take up the receptors. So the number of active receptors there are very few. But the other thing, why he is able to do it initially, because there is a concept of quantum release of neurotransmitter. Okay. So you have got a specific amount of neurotransmitter that is stored in the presynaptic terminals, and then there is a specific rate of production of this neurotransmitter. So initially you have got sufficient to overcome the deficiency, but as you do repetitive work, the total amount available becomes less, and the person becomes unable to control the skeletal muscles. Okay? So this was the first complaint. The person, I distinctly remember, he said that I was driving and suddenly the eyelids fell down. The eyelids fell down. The only way was just to get hold of the eyelid and take it up. And similarly, the other symptoms, they started appearing. A repetitive activity, this is the key thing. The thing which is being repeated would consume the acetylcholine or whatever is stored, and you need extra amount of acetylcholine to overcome the defect. So that extra amount is no more available with repetitive activity.
So now we take over, again we come to an actual component. Since they're saying eyelids, you have not done muscles of the eyeball, but you know the muscles in the face. So now which is the muscle for the eyelid? Yes? Orbicularis oculi. Then, not orbicularis oculi is for the horizontal.
I know they have not done eyeball muscle. So orbicularis oculis is what they know for the face. So this muscle helps do that. Yes, close that. And what is the nerve supply? Okay. So all the muscles of the face are supplied by facial nerve. Then what are the muscles of the name the muscles of the face? Forget the face nerve supply. Name some of the muscles in the face which you know. Sorry, ma'am. Yes. Occipitofrontalis. Then yes. Vaccinator, yes. Orbicularis oris. Maxillary what? Zygomaticus. Sorry? Masseter temporalis, yes. He said maxillary. So I assume he's telling masseter, yes. Masseter temporalis. Then anything else? Anything else? So these are the names of the muscles that you see in the face. Orbicularis oculi around the eyes, oris around the mouth, vaccinator. Zygomaticus major, minor, corrugator superciliate, and all these names. Okay. Now, nerve supply is facial nerve. This you know, yes? And now coming to what is the sensory nerve supply to the face? Trigeminal. Okay, good. What are the branches of the trigeminal nerve that is supplying the face? Yes. Okay. Now I want other boys to answer. Where is the ophthalmic division of the trigeminal nerve supplying the face? Which part of the face? Forehead, girls. Where is okay? Maxillary nerve. Where is maxillary nerve supplying the face? Which region?
Maxilla.
Maxilla. Around the maxilla. Where? Is the nose supplied by maxillary nerve or the ophthalmic division? Nose. Depends. Depends on what? Depends on what? Depends on if the face is chubby or thin. So now, maxillary ophthalmic division supplies the nose, conjunctiva and mouth. And the maxillary nerve supplies the cheek. Yes, mandibular nerve, mandibular vision. Okay. So these are the divisions of the trigeminal nerve supplying the face. Now coming to the symptoms of myasthenia gravis. Here, why do the symptoms worsen by chewing and reading? Yes, why does the symptom become worse when the person is chewing?
Because in myasthenia gravis, there are less receptors. So when we put the contraction, they are defined.
Okay. Fatigue. Yes, they can. So there is fatigue. Now coming to the next part, what are the investigations that is done here? A serology test, positive for anti. Okay, one of you please read. Who will read? Read please. Girls. Yes, please read.
Serology positive for anti-receptor antibody, which are commonly evaluated in patients.
Why is this elevated? Anybody can tell? Receptors are not using it up. Yes. So electromyography shows. Yes, please read.
Electromyography shows a response to consistent with neuromuscular transfusion.
Okay.
On examination, cardiorespiratory systems were fine and had no obvious clinical manifestations except for reducing muscle power on assessing
So now coming to Dr. Fatil. No. The pharmacological part of the case.
So this is the last case. So just we need to link the pathophysiology with the pharmacology, right? So in the previous slide, what type of the examination they have been done? Excuse me, for what? So this is the receptor, right? So if we have this antibody, right, and this antibody attack اللي هو muscarinic nicotine receptor, your muscular junction, right? So what happened with this receptor? The number of the receptor decrease, right? If we have reduction in this receptor, what happened for the ligand acetylcholine? It will be useless, right? Okay, so we have this. So that means we're gonna have a reductions in the acetylcholine receptor, right? So that means we need more acetylcholines in the muscle junction, right? So, right? We need to increase this one, right? So there's two ways to there's two ways to activate this pathway. Either we're gonna use acetylcholine analog, right? Or indirect, right? So the cholinergic agonist, we have two types, right? We have direct and we have indirect. Let me make a quick recap. So for the direct, how many types of acetylcholine receptor we have? Muscarinic and nicotinic acid. Can you give me example for muscarinic receptor agonist? Bilucarb, right? For what use this one bilucarb? The indication. Hydroxybilucarbon used to treat glaucoma, right? Okay, we have another drug for acetylcholine. Can we use acetylcholine? Why? Short time. Okay, can you give me an example for the nicotinic receptor agonist? Tobacco? Nicotine, you're right. So this is direct. What about indirect? What do we mean by indirect? Agonists. Inhibitors, right. So we have two types, right? Can you remember? We have reversible and reversible. What's the example for reversible? Physostigmine and investing, right. What can you give me example for the reversible? Good. So now, what type of the cholinergic agonist is used to treat myasthenia? Is direct or indirect? Indirect. So, yeah, you're right. So, if indirect, so if it is indirect, it will be what? Acetylcholine inhibitors. Good. So reversible acetylcholine esterase inhibitor. What is this enzyme? Break down acetylcholine, right? Okay, acetylcholine can reuptake for the as a neurotransmitter. Acetylcholine can reuptake? No. The once they release it will degrade it, right? To the acetyl and choline reuptake again and resynthesize again, right? It's not like serotonin or norepinephrine. Correct? Which acetylcholine esterase inhibitor drug used to diagnose myasthenia gravis? And why? So, okay, what's the acetylcholine esterase inhibitor used to treat? Physostigmine, right? Okay, and we have another one. Can you remember it? Pyridostigmine, right? So what's the difference between pyridostigmine? So pyridostigmine cannot cross the blood-brain barrier, and physostigmine can cross the blood-brain. When we can we use pyridostigmine? Why? Because we don't want to cross the blood-brain barrier and cause CNS adverse effect. Correct? But when we use pyridostigmine, if we have toxicity for atropine. Why atropine? Because it can cross blood-brain barrier and can cause adverse effect. So, interferon, why interferon cannot cross the blood-brain barrier? Yeah, right, quaternary. Because they have positive charge. So, interferon hydrophonions because it's temporarily increased the levels. I think we are done. Okay, which acetylcholine drug used to treat myasthenia, we say? Vertustigmine. Vertustigmine or physostigmine? Huh? Right. I think we finished. Ah. So this one should be come before. Yeah. So the physician suspect the myasthenia gravis and injection hydrophonium. And you know why hydrophonium, right? Temporary. So what happened temporary? Why we use it for diagnosis? I know. What happened after we diagnosis? I know. Why we use it as diagnosis? Because if the symptoms relieve, okay, this confirms what we have, myasthenia gravis. Correct? So acetylcholine esterase inhibitors, 10 milligram terginsal bolus after those improvement in the weakness occur within second. That lasting for 3 minutes. Why lasting for 3 minutes? Because short duration of action. While waiting, just I want to correct this one. The drug should be physostigmine. No, this one, vertustigmine should be physostigmine. Physostigmine, because this is kind of cross the blood-brain barrier. Okay, I'm not going to take it to this one. Okay. Immediately, I think, taken.
Answer immediately felt better while taking drugs. Strength return and meanwhile the antibodies test were positive and confirming the diagnosis of myasthenia gravis. Now here we need to check for what's the difference between upper motor and lower motor lesion, because here they have muscle involvement. So what's the difference between upper motor and lower motor lesions? Yes, yes. Sorry? Reflexes and yes.
Spastic paralysis and Lewinsky cycles.
Okay.
Upper motor lesion should be inhibited. If it has an upper motor lesion, that will more excitation.
Exactly.
Upper motor will be
Okay, so this is the answer for this case. So with this, we finish myasthenia gravis case. Now let me just quickly go through the.
Just a minute. That drug is correct.
So that was correct, doctor. Okay, so what Dr. Fazil is trying to tell is this is correct. The pyridostigmine is used. This is correct. That's what he's trying to tell. So just a minute. So now, Dr. Okay, we come to case 3 now. Very quickly, it's the last case. We finish this case, then you're free to go. So, students, just listen to this case.
Again, Assalamu alaikum. This is the last case.
Yes, last case. And let me tell you, we are going to include questions from the skeletal musculoskeletal module. You know your blueprint, right? So there will be questions from this. That's why I was asking all of you that you need to attend this session, very important. But it looks like people are not serious. But this part is very important because the one chunk of the questions in the exam will come from these sessions.
So this is so anyone?
Yes,
Also,
please.
yes, please.
Dr. Here she wants to read, yes.
So part 2. Okay, part 1, part 2. Okay.
46-year-old has
Stefan صوتك شوي.
throughout his life has recently been experiencing loss consistency and long run, which he was doing every 2 days while training for a marathon, during which he sweat or breathed. Other cramps.
Thank you. So this is Suleiman, 46-year-old. He participated in marathon. Huh? Which type of muscle used here, Shino? لا لا. Type muscle. Type 1, type 2. Type 2. Type 2. Which type 2? Subtype? Why type 2? Why type 2? Endurance. Which type of fibers suitable for endurance? Huh? Type 1. Type 1, not type 2. Type 1. What is the other name? Slow oxidative. Slow oxidative. So this gentleman is using type 1. Can we increase the bulk of this muscle in our body? Why? ليش؟ Genetic. Which types can be interpolated? Huh? Type 2. Type 2. Depends on how we can improve type 2 or through what? Okay. Depends on? Yeah, depends on the type of activities or exercise. So you can improve your oxidative or aerobic or anaerobic activities. طيب, the second part of the case من كان بيقرأ؟ أي تفضل. Other cramps, yeah, wait.
Other cramps are still frequent, occurring in the house for sometimes every 3 months and 3 weeks duration. General medical is normal physical examination of lower limbs. His Achilles tendon was intact and normal. Urologic examination is normal.
So everything looks fine, yeah? I think we have some anatomical questions now. Doctor, we have some anatomical questions?
Yes. Yes. So now coming to the question here, since we are talking about muscles, we need to talk about the muscles in the posterior compartment of the leg. You saw the answer. Okay. One minute. I don't want you 3 boys answering. I want her answering. Anybody else? Yes, there. Yes.
Gastrocnemius,
Okay.
soleus,
Yes.
plantaris,
Okay.
tibialis,
Posterior. Then you have 2 muscles which are going to the feet. Yes? That is flexor temporum longus, flexor hallucis, and longus, and complete. Where is it completely? Behind the knee. Yes. So now, next question? What is tendoichilus? What is tendoichilus? No, I know you can answer. Yes. Somebody who is not answering now. Yes. So what is tendoichilus? What is tendoichilus? Yes.
Combination between gastrocnemius and soleus forming
It is a tendinous insertion of the 3 calf muscles, soleus, plantaris, and gastrocnemius together. What is it? Where is it inserted? Where is it inserted? Yes. What is the action? Plantar was a nerve supply. Tibial nerve. Now look at that. The function is powerful plantar flexion of the ankle joint. Yes? And what does it help us do? It helps us propel forward when you're walking, the walking cycle. Yes. And what is it supplied by? Tibial nerve, component of the sciatic nerve. Now, what are the other movements at the ankle joint? What are the movements at the ankle joint? Subtalar joint, metalar joint. Ankle joint, what's the movement? Anybody? Dorsiflexion, plantar flexion. What is the action at the subtalar joint? What go the metatarsal joint? Every action. How? So you have dorsal flexion, plantar flexion and ankle joint, subtalar joint and metatarsal joints. You have the, I forgot to mention that inversion and eversion happens in subtalar and the metatarsal joints. Okay, so I forgot to mention that. So now coming to the metabolic causes of the cramps, which Dr. Shakil will.
Thank you. Yes, can first of all, good morning, everybody. So, what do you think are the minerals which is involved from muscle cramps? Yes. Yes, calcium. Apart from calcium, sodium, potassium. One more, magnesium. So mainly these four minerals is involved in muscle cramps. Now, do you think it is because of the deficiency of these minerals? It might be because of imbalances of these minerals. So there are metabolic and hormonal disorders which can lead to imbalances like hypokalemia, hypomagnesemia, hypocalcemia, or hypothyroidism as well. Can dehydration cause muscle cramps? Yes. Dehydration can lead to muscle cramps with the inadequate replacement of the salt or the potassium affecting dialysis. What is the difference between nerve conduction defect and neuromuscular transmission? This is not related to me. I didn't do this. Yes. Nerve conduction defect and neuromuscular transmission defect. Yes. This is not mine. Okay. Covered. Now, so this is now the biochemistry part. It is related to various minerals, particularly imbalances related to sodium, potassium, calcium, and magnesium. First of all, let us see calcium, the most important one. What is the role of calcium? For the muscle contraction by, okay, and the other thing, actin-myosin, interaction between actin and myosin. So it is related to muscle contraction. So naturally, if there is insufficient calcium, it can lead to prolonged muscle contraction, or there will be disturbances in the muscle contraction leading to cramps, particularly during exercise. Which is the second mineral after calcium? Potassium. Sodium. You know very well, sodium is required for maintaining the fluid balance and also for transmitting the nerve impulses. So naturally, if there is imbalances related to sodium, particularly decreased sodium, that is hyponatremia, it can result in disturbances in nerve signaling, leading to involuntary muscle contraction, which will be manifested as cramps. Is it okay? Next, what is the next mineral? Potassium. You know potassium? It is the main intracellular cation. It is also concerned with contraction of the muscle and nerve function. So naturally, hypokalemia, that is decreased potassium level, it can impair with the muscle relaxation, increasing the excitability of the muscle, which will be manifested as cramps. Is it okay? Now the last one, magnesium. You know magnesium related to muscle relaxation and also required for the energy production. So naturally, if there is a deficiency of magnesium, that is hypomagnesemia, it will lead to disturbances in the neuromuscular excitability, leading to cramps. So as I already told you, it is not related to the deficiency of the mineral. It is related more to the imbalances which can be created because of a number of conditions. So it arises because of disturbances in the electrolyte balance affecting muscle contraction and relaxation. So what is the key then? One should maintain adequate hydration, adequate balance of these minerals, that is calcium, sodium, potassium, and magnesium. This is all as far as the biochemistry part is concerned. Thank you.
So after this journey now, the conclusion is the treatment and diagnosis. The patient was reassured that the baseline in infrequent muscle cramps were not due to a significant medical or neurological condition, and this was further confirmed by the normal examination, screening, labs, and electrophysiological studies. Finally, they give him just only symptomatic support represented by B-complex vitamin supplementations and some stretching for the calves before bed to minimize the occurrence of infrequent cramps, and also the patient advised to take excessive salt or to replace the excessive salt sweetening by using salt tables. ايش يسمى salt tables يا شباب بالعربي؟ ملح أو المائدة. أي. So it is advisable, especially in hot weather before exercise, as Dr. Shakil said, that to take care about the hydration status, fluids and electrolytes. So before exercise, advised to take salt tables and aggressively hydration during races. We're advised to help and minimize this cramp, and also allow participation in races without limitations. So that's all for our today, inshallah.
We have to microbiologically discuss the microbiology components just to wind up. So what we did try to do here today is we try to get different type of cases, not only injuries, metabolic cases, neuromuscular disorders, so that you get a whole wide range of covering of the different cases that can occur in the muscle. It's not always muscles, joint, bones. You could have metabolic disorders, you could have disorders with the neuromuscular junctions. So with that we almost come to, except for this part where we have a bit of microbiology. Yeah, we have Dr. Prof. Ayman here who's there to discuss with you the swab and from here.
Assalamu alaikum. السلام عليكم. يعني احلى دفعه ان شاء الله، ما نعرفش لسه، هتعرف بعدين ان شاء الله. Explain why you collect sample. The first, what would be the further management to prevention of diabetic ulcer? طيب ناخد السؤال الاولاني. The first question is explain how to collect the sample from the wound. Swab and circular motion. Actually, I'm not microbiologist. I'm the worst. Your knowledge better than me in microbiology. It's okay, I'm working only in parasitology. But you should take it under certain circumstances. I don't know if those circumstances or not. Unless you will take saprophytic and commensals bacteria. So you have to make it in a certain maneuver. It's not mentioned here. How complete isolation, identification, safety test of the host organism is done in the microbiology lab? How? Anyone know the sequence? Processing of the sample is called sample processing for diagnosis. What we do exactly? فين؟ حد كان بيتكلم هنا؟ Is someone is going to answer? Yeah, go on. Okay. Okay, it's called culturing. So you culture the sample and then we will got isolates, which is colonies, and then And why you do these tests? Actually, yeah. The first thing is to culture. Then you try to identify either morphologically, so you can make staining, gram stain, and then or special stains like acid-fast stain. Then you do biochemical reactions to identify. After you identify, what you do? Yes? Okay. All of this characterization of the organism. What is the last and next step? Sensitivity. Actually, yes. Then we do sensitivity. I'm not biased by the female. I will come back to you in yours. So, because they continued and they are like a chain, so I let them to continue. It's okay. It's a cascade of ideas. It's okay. So, actually, the last step is to do sensitivity. So, as you said, agriculture for both aerobic and anaerobic, and then isolated organisms will be then identified by manual or automated techniques, followed by antibiotic susceptibility testing. We end with antibiotic susceptibility testing. Perfect. What is the most important step in diagnosing skin infection? Actually, if we come to the microbiology, it means we already finished from clinical examination. So yes, you're right. But now we are in a laboratory diagnosis. Laboratory diagnosis means we already finished the history and the clinical examination. Yes. Yeah. Yes. Actually, the clinical symptoms, which is guiding the specimen collection, which is specimen, and who's going to process the specimen going to process. Separate normal flora. I don't know how. If you know, it's good. It's okay. You know how? Yes. Perfect. Yes. So you choose selected media. Okay. Yes. And then. Okay. Swab culture is the gold standard diagnostic method. So usually we make a swab culture. This is the standard. It's okay. It's a question out of topic. It's okay. The rule in microbiology is to culture first. This is the rule. Yes? It's a gold standard. Gold standard is culturing. How many parasites can be cultured? As a first step, parasites. How many parasites can be cultured? 3 4 5 Nothing. Yes. We don't have culturing in parasitology except in only one organism, which is a commensal organisms. Nowadays we started to be interested in culturing. So, and you're going to know these organisms in the GIT module, inshallah. So we don't have culture. We're not like microbiology. Okay. So this is not the gold standard for us. The gold standard for parasitology is microscopy. So 60 to 70% all over the world diagnosis of parasitology depend on microscopy. So, okay, gram stain revealed gram-positive cocci in clusters and gram-negative bacilli. What are the common organisms that cause wound infection in diabetics? Staph, okay. Neisseria. I don't agree or disagree. I'm just enumerating the names. And again, Streptococcus. Yes. Neisseria for sure. If you answer Neisseria from the beginning, I will not look to the list of the answers and I will give big 0. It's okay. So let us do. So gram-positive bacteria such as Staphylococcus and beta hemolytic streptococci. Okay, perfect. The category of the organisms that cause diabetic foot wound infection are usually anaerobic, or we speak about gram. Perfect. It's a polymicrobial. It's okay. This is the key for diabetic lesion. We have a polymicrobial infection. Usually, you don't have a single organism. We have a polymicrobial infection. So polymicrobial, gram-positive, gram-negative, and anaerobic. كل البكتيريا هتلاقوها هنا كويس تمام في diabetic especially. But you should know why. Okay. I have a question. I have only one question. I have 1 minute. Okay, perfect. It's okay. So I have only one question, and I need only one to answer this question. And this question is, anyone is going to answer this question, I'm going to give him a real papyrus paper, okay? and this is a bookmark. It's okay. So it's yeah, for parasitology, of course, it's okay. No. The question is, which parasites can cause creeping eruption and mention the causative organism at each parasite? Which parasite can cause creeping eruption, skin creeping, okay? And at each case, you have to mention the causative organisms. Okay, some of you are shy to answer, and some of you know the answer, don't like to answer, but I would like to make sure, how many of you know the answer? It's okay, I don't want to answer, it's okay. How many of you know the answer? Even is not complete answer. How many of you have an answer? Okay, now, let your hand down. Who would like to answer? Okay. I have an idea. This is the middle section. Which one you choose of the three? Abdulaziz. Okay. Abdulaziz. لا. عبد العزيز هيجاوب ولا ياسر؟ استمر. طيب. اتفقوا البنات هتختاروا مين يجاوب؟ مش غير واحدة. نعم؟ شفتوا الفرق؟ هو الفيميل decision. So easy to take a decision. It's okay. But they take time to take a decision. It's okay. Male don't take time to take a decision, but they take multiple decisions. It's okay. So, okay. Who's going to answer? Abdulaziz or Yasser? Yasser. Okay. هو هيجاوب الأول and you will correct him. It's okay. And now I have two of this. It's okay. For sure, Yasser, if he completed, he will take it. And you will take an award. If he couldn't, you will complete and you take the prize. It's okay. Go on. Cutaneous larva migrans and the causative organism is? Okay, and the second one is? You are correcting him, huh? It's okay if you have a correction. So let him to finish, then you correct it. It's okay. The second is? Second one is leishmaniasis by sandfly. It's not the causative organism. This is the mode of transmission. This is not the causative organism. And third is scabies, and the organism is Sarcoptes scabialis. Okay. Now you have a chance to. You agree on what he said? Sarcoptes scabialis. I don't say all of them. I would like to enumerate them. So first one, he said that. First one, he said, cutaneous larva migrans. You agree or not? Agree. And he said the causative organism is leishmania. You agree or not? You have to agree or disagree, just disagree. So the causative organism of larva migrans is a cat. Ascat ankylostoma. So it's not leishmania. So it's a helminth, not a leishmania parasite. So this is wrong. And the second thing, he said leishmania. You agree with leishmania making creeping eruption or not? You don't agree. So okay, what you agree on scabies and cutaneous larva migrans. There's a third one. Third one. Schistosoma. Schistosoma don't making a creeping eruption. Creeping eruption means we have something which is creeping, which is moving under the skin. So lice don't creep. Lice make and tool a scratch when it at the place of biting. Mites, we have Sarcoptes scabialis, which is one just creeping one. Hookworm is the causative organism of cutaneous larva migrans. Perfect. Which one? Okay. Can anyone help him? Okay. What is the third one? The third cause of creeping eruption? Go. عادي بيقول الشيستوزوما لا ما بتعملش كريمين. Meiosis, yes, meiosis. We have two types of meiosis. We have cutaneous meiosis, which is two types. As a nodular one, which is we'll go over the differential diagnosis of leishmania, and we have the creeping one. So which one in your opinion when I should take this one? Yes, sir. Or Who say yes, raise his hand. Perfect. You have to encourage your friends to attend. This is the idea. So he support, أنا ديمقراطي كويس. So I will give both of them answers, okay? Be democratic. Daily to work on this. So she did a great effort. It's okay. Even when I compare my effort with Dr. Sujata, I feel maksoof. I feel yes. So thank you so much, and we appreciate.
Did you all benefit from this session today? Yes. Thank you. So now we want to thank you for listening to us and wishing you all the best for the exam. But we have a winner. Who should be the winner now for this? Now let me tell you frankly, there were 4 boys here, 4 or 5 boys here. Yes, can you please stand up? What's your name? Abdul Aziz. Mashallah, you? Yes, what's your name? Okay, I still can't get it again. Yourself here, these 2 boys, here 1 boy. 5 boys were very active. You also, please. Yeah, these are the boys who are actively answering my question. Okay. Then among the girls, I have your name, please. Yes. Girls. So we have girls. Most of them were answering. Let me tell you, girls, they were answering, but they were not confident to tell it loud and answer. But I agree. I'm not supporting them. I really mean, but hands off to all of you. So I think the winner should be both boys and girls. No, but see, but okay, now it's not